Hi, everybody. Thank you for joining us today. As Madeline mentioned, my name is Diego Henriquez Garcia. I am an enterprise account executive here at Modern Health and very excited to introduce you to Dr. Celeste Watkins-Hayes. Welcome, doctor. Thanks for joining us.
Thank you. I am so excited to be here. Thank you for having me here.
Gladly. And so Madeline kind of teased what Dr. Celeste Watkins-Hayes does, and she has such an extensive resume that we could probably read the whole thing for 30 minutes, and she would never show off, so I'm going to do it for her. So Dr. Watkins-Hayes got her PhD from Harvard Sociology Department and multidisciplinary training program in inequality and social policy, and then went on to be a trustee at Spelman College, which is her alma mater. She then taught at Northwestern, go Cats, where she was named the Associate Vice President for Research and Chair of the Department of African American Studies. That's actually where I had the privilege to meet her in her Introduction to Inequality class, and then even more luck to be her graduate assistant for 4 years, pretty much, which is great. So you saw me go through a lot, and I learned a lot from you. And now Dr. Watkins-Hayes is currently the Jean E. Fairfax Collegiate Professor of Public Policy and a Professor of Sociology at the University of Michigan. And most excitingly, just published her book, Remaking a Life, How Women with HIV/AIDS Confront Inequality. And I know that that's the culmination of years and years of research around inequality, public policy, race, social safety nets. So lots to dive into today. But the book is already being lauded by everyone from the American Sociology Association to Stacey Abrams to even Jonathan Van Ness. So your work and scope are extremely impressive, and we could not be more thankful to have your time today, Doctor.
Thank you. I'm so happy to be here. And please, Diego, call me Celeste.
Okay. It's weird. You were my boss. You were my professor. Well, congratulations on the book. I remember reading all those transcripts, and it's been really powerful to see it all be contextualized and come together. And one of the things I was thinking about a lot today is how different the world was when the actual interviews happened to then when I was reading them to now that the book was published. And so there's a lot of collective hardship that's happened throughout all of them. And I think it'd be really important to start with you sort of connecting those dots for us as to how your research on HIV and women dealing with these issues connects to what we're all going through collectively as a nation and a world during the COVID era.
Absolutely. Well, the first thing that I want to say is we can never underestimate the power and significance of people being able to tell their own stories. And the book project, Remaking a Life, is based on women telling their own stories. We saw the rise in the numbers of cases of HIV among women. We know that we've been grappling with the HIV epidemic, discovering it in 1981, and it has been a decades-long project to fight this epidemic. And what's always been central about HIV, for those who remember hearing about the first cases in the 1980s, in the 1990s, and perhaps still continue to hear stories and perhaps have people in your life, or maybe you're even a person who's living with HIV, is that you know that the story of HIV is a story of storytelling. It became critical for people to understand beyond the illness, beyond the disease, to understand that we were talking about real people who were being affected and real lives that were being affected. So whether it was some of the films that we saw that illuminated the lives of people living with HIV, or plays, when we think about Philadelphia and Angels in America and The Normal Heart, and the way that we kind of came to understand the HIV epidemic, Pose, the TV show, the excellent TV show would be a current example, to the work that I did gathering the stories of women living with HIV, interviewing them, and those are the transcripts to which Diego referred. The way to understand where we are, the way to understand the human condition, is to really center stories and giving people the opportunity to tell their own stories. Why is that important? Number one, because you allow them an opportunity to be heard. what we are seeing right now, when we look at our current landscape, when you think about the rise in the importance of mental health services, when you think about the HIV epidemic, as I connect those threads, the need to be heard proved to be critical for the breakthroughs to happen, right? We had to be able to let people know, particularly marginalized people who often never get the microphone, who
Mhm.
never get asked to tell their stories, who never get the opportunity to help voice something that informs policy and informs practices subsequently. Is what we gather from that is absolutely critical. So the work that I did, the work that I continue to do, and what I'm seeing right now in our larger conversation is the importance of storytelling to give people their own voice, to be able to understand their perspectives, and for people to be able to point to what their needs are in a way that's not stigmatizing, in a way that honors and affirms who they are, and that allows them to be agentic in finding the solutions that are going to serve themselves and their families. So that's what we set out to do in Remaking a Life. We interviewed women about their lives. We asked them about their children. We asked them about their relationships. We asked them about their work lives, their childhoods. We also asked them, yes, about the story that they received, the day that they received the news that they were in fact living with HIV. And through gathering those stories, we were able to situate that in a broader landscape of the HIV epidemic and the movement that we've seen over the last 40 years of HIV moving from a death sentence or a perceived death sentence to a chronic manageable illness. In order to understand how it is that HIV is effectively a manageable health condition that can be addressed with one pill a day, you
Mhm.
have to look at the stories of the people who got us there. So that I think is relevant for us today as we live through this moment of COVID. And what I hope that we're doing is kind of turning up our listening ears and recognizing that as people experience this pandemic in all kinds of ways, as they reflect, as they voice, they're pointing to solutions and they're pointing to needs that will show us the way forward.
Well, thank you. One of the interesting parts that I've definitely noticed in comparison to the HIV epidemic is it's definitely affecting marginalized people more, but in 2020, we've also had racial unrest and marginalized people rising up a bit more and having more of a voice, even if it was forced, with their local, state, and national governments. And so the other thing is that the HIV epidemic, while it was present for everybody, um, wasn't necessarily that was hit home, right? People knew about it, they read about it, but they didn't have to stay inside because of it,
Mhm.
right?
Yeah.
And so, can you talk to me a bit about the parallels that you've seen with the policy and government response around HIV and the policy response that we're seeing now, and how that affects the communities that you've researched?
Yeah, that's such a great question because when the pandemic started, people looked to the HIV community. When the COVID pandemic started, people looked to the HIV community for lessons learned. And there are a lot of parallels, both pandemics where we're dealing with a mysterious illness and we're very much kind of racing against the clock to save lives and really trying to push the scientific advances as effectively and as efficiently and safely as possible. Number two, we are seeing a government response that is leaving a lot to be desired for many people. That was the case with the HIV epidemic, with the reluctance on the part of the federal government to even talk about the epidemic, the HIV epidemic in a systematic way, in a real reluctance to be able to be willing to speak truth to power and make sure that the federal resources were being commanded. Although, interestingly, there was a kind of a couple of voices within the federal government that were pushing back on that. So for example, the Surgeon General at the time the HIV epidemic kind of got discovered, C. Everett Koop, sent a pamphlet home to every American household explaining this is HIV, this is what we think causes it, this is how you can protect yourself. So there were these instances of mass communication to try to educate the public even in the face of resistance within the government itself.
Mm.
COVID, we're seeing something very similar, right? We're seeing a federal response that that has been challenging, that has been widely criticized, and then you have voices from within the federal government. So, for example, Dr. Anthony Fauci, who are nevertheless really taking it upon themselves to educate the public. So the parallels are eerily similar. The
Mm.
other thing that's similar is the fact that we're dealing with a crisis within a crisis. So the idea that while we're dealing with illnesses that can affect anyone, so there's a kind of universal aspect to HIV, anyone can contract it. There's a universal aspect to COVID, anyone can attract it. The kind of crisis within a crisis is showing that there's still major disparities happening, where we saw early on groups that were disproportionately affected with HIV, and then groups that are disproportionately affected with COVID. Racial minorities, low income people, people who have limited access to resources to protect themselves, in both instances, in both epidemics, finding themselves highly vulnerable. One distinction is that with COVID, the universalism is felt in a very real way, right? So while people may theoretically understand that anyone can contract HIV, the big difference here is people understand that anyone can contract COVID, and they have seen their lives upended as a result. So that distinction has created a whole nother sociological ripple effect. That makes COVID distinct from HIV in terms of sheltering in place, staying at home. We just talked about the fact that, our children are home, or we had to make the decision to send them to school if our schools were open, and with a whole new series of safety protocols. And we kind of live with that sense of anxiety and vulnerability as we kind of move through the world in the era of COVID. So what I think the lesson learned as we look at the similarities and differences between them is, number one, in order for an epidemic to be addressed, there has to be that strong coordinated response at the level of federal, state, and local government. That's what moved the needle on HIV. And we're hoping that at some point, that's what's going to move the needle as it relates to COVID. The second thing that's to be learned is the voices of activists. So it was really beneficial for people to hear from the people living with HIV and those most affected. They pushed the scientists, they pushed for public policies, they advocated for themselves, they educated the public. And what I predict going to start to see is more of that activism coming out of the COVID pandemic, where I think you're going to see a very strong activist push to protect healthcare, to really, and for the purposes of modern health, I think you're going to start to see calls for not only us addressing physical health, but mental health.
Yep.
To really take on what is the emotional toll of COVID on in a whole host of areas. What does it mean to feel that kind of bodily vulnerability? What has it meant for people to try to juggle work and family in this very kind of high pressure environment, where it may feel like the obligations at work have not subsided, but the obligations at home have increased exponentially. And all of that wearing on people, and then people seeing the social unrest and seeing it and experiencing it in a visceral way. Marginalized populations have always known that we are under attack. It is throughout history that we can point to the various ways in which people have been killed or incarcerated or impoverished because of the color of their skin, because of who they love, because of their gender identity, etc., because of their, so on and so forth. But what we're seeing on our screens, both on our television screens, but on these little handheld screens that are appendages for us, are the real visceral images of what oppression looks like. To see a person dying effectively on camera, and it's not fiction, it's happening before your very eyes, as a knee is placed on the neck of a man in the street by an officer who we hoped would protect, has a visceral psychological reaction that is not just about that moment, but that lives within the person's psyche that has to be then grappled with, right? That sense of horror, that sense of vulnerability. And that's just one instance. We've seen many images that have been triggering for people as we think about the social unrest and how that gets layered on to what we're grappling with COVID. So we
Well,
are perhaps in one of the most challenging times psychologically in terms of our mental health that many of us have faced in our lifetimes, to be quite, I think I would go so far as to say that.
well, absolutely. And that's the reflection that we're seeing with how we're working with our clients and our members. And that very much also connects to how you're talking about lack of access to resources. I mean, our mission is to create more equitable access to mental health resources. And that's why we're seeing such popularity, because COVID has very much pushed this into the forefront. And at this point, I don't see it going back, right? There are a lot of things boiling under the surface around mental health and lack of access to mental health resources, and the conversation around preventative mental health. I mean, we don't need to make this into a sales pitch, but this was always necessary, and now it's just more urgent. But I want to move a bit towards that, right? And the title of today's talk, which is Thriving Despite.
Yeah.
So we've set the groundwork, right? And it's very easy to go into a bad news wormhole or talk about all the things that are going wrong. But during the AIDS epidemic and the HIV/AIDS epidemic, as well as throughout your research, you were finding women who weren't just surviving; they were thriving despite their diagnosis. And there's a lot of themes in that I think we could learn from, because a lot of your subjects were still these most marginalized people. I mean, some of the transcripts I remember reading were heartbreaking, and they were still thriving despite, and rebuilding and remaking. So what lessons did you learn from them, and did you highlight in your book that everyone on today's talk can apply to their own lives when just trying to cope and work through what's happening today?
Yes, absolutely. Right. Because, and the last thing I want to, before I pivot to that, want to do to kind of set the context is, imagine that when crises hits, we may all feel as though we're in the same boat, but we're not in the same boat. Some of us are dealing with crises from the comfort of yachts, and some of us are dealing with crises from the struggle of rowboats. So what you are pointing to in the work that you're doing at Modern Health is how to equalize that, right? So that when the storms of life rage, there's not such a disparity between the yachts and the rowboats. The rowboats are strengthened, they're given more resources, they're given what they need, they're maybe moved into other boats. Essentially, they're resourced to be able to navigate those storms. So how did this happen in the case of women living with HIV? Turning directly to your question. It is absolutely the case that we saw some significant struggles. We met a lot of women who were huddled in rowboats, to be quite honest with you, who were grappling with a whole host of issues, the stigma and shame of finding out that they're living with HIV, the aftermath of sexual violence and sexual trauma that they had experienced in their lives that then had downstream consequences for their ability to protect themselves from acquiring HIV. So whether it was the incident itself that might have led to an HIV diagnosis, or the incident happening early in life and leaving such kind of traumatic damage that it shaped how they navigated relationships, how they thought about their sexual health, whether they self-medicated with drug and alcohol use, whether they struggled with a whole host of issues that made survival very difficult and made them very vulnerable to entering into perhaps a relationship where in fact they acquired HIV. So what we came to understand as women talked about this movement that they were experiencing, from what I call dying from to living with to thriving despite, dying from being this severe state of crisis where everything seems to be caving in on you, emotionally, economically, social, everything, to living with where you're to a place of stability, right? You're maybe going to see your doctor, you're getting the diagnosis, you're getting some preliminary information about your health, you're starting to kind of be able to manage that. You're getting to a place of economic stability, you're getting to a place of social stability, all of those different sectors of our lives, getting to a place of some level of stability, to thriving despite, which is you're still grappling with the realities of an HIV diagnosis or other things happening in your life. They may not go away, but the way in which you respond to them is very different because you have a new set of tools and you're moving to a place where you are thriving despite that hardship. And in fact, you're able to start to take a leadership position in that. You're able to speak to others, you're able to advocate for others. Maybe you're talking to policymakers, maybe you're advocating at your employer on behalf of the other employees who need the same kinds of tools and resources that you do. You're beginning to be a public voice in the struggle to not only help yourself as you were in the kind of living with phase, but beginning to help others in the larger society, which is what we saw in the thriving despite. So imagine women being diagnosed HIV positive and that traumatic experience that they talk about around the diagnosis, situations that might have been happening prior to the diagnosis, their lives after the diagnosis, being a place of dying from. What moved them to living with is the following. Number one, access to healthcare. And when we talk about healthcare, access to, yes, HIV doctor who will check their viral load and T cell count and prescribe the medication, but often more importantly, access to a mental health provider who's helping them deal with the stigma they may experience, the shame they may be feeling, and all of the other life events, the traumatic life events, of which HIV might have just been one of those things, right?
Well, and sorry to interject here. What we see throughout our research and through a ton of research as well is the comorbidity rate between someone with some sort of mental health diagnosis or struggling with their mental health, right? We all have mental health, but some of us struggle with it, and the correlation to their physical health, right?
Yes,
so
that relationship.
And part of the reason that a lot of the partners we have are there and working with us and really working towards this is starting to notice that relationship. It's not just about those that are depressed, it's about those who may increase or experience above average anxiety, but that's hurting their diabetes, it's hurting their heart health, it's hurting their,
absolutely.
I mean, it's connected to everything. So that has to be even worse when someone has a chronic illness like HIV.
Absolutely. And the HIV community were early understanders, if you will, of that relationship. They really understood that in order to treat the HIV, you also have to treat the other kind of mental health factors that are going on. So number one, access to healthcare. Number two, access to economic assistance. So whether it's helping people, whether it was women getting better jobs, women getting job training, women getting jobs within HIV organizations, women getting access to government assistance, there needed to be an economic safety net, because if you are worried about where your next meal is coming from, how your kids are going to eat, where you're going to live, you can't attend to the mental health. That's a mental health risk. That's a mental health trigger. That's a physical health risk. That's a physical health trigger. You're not going to be able to focus on the first thing that I talked about if you're worried about the vulnerability in the economic realm. So that was the second thing that the HIV really thought about deliberately.
Well, and with mental health right now, an average session can cost up to $250. I mean, even if you are relatively economically stable, it is unfortunately become a privilege to see a coach or a therapist or a psychiatrist, unless you have $250 for an hour-long session, and then can even find someone to take that money from you. I mean, sometimes you have the money and there's no capability anyways. So access is still an issue.
Right. And what we're learning from COVID, just to kind of, really connect it, is people who have experienced a COVID diagnosis are now seeing the economic implications of that. They're now getting the healthcare bill, the medical bill for the services they got. Or if they didn't get a COVID diagnosis, but they had another illness that they put off on treating because they didn't want to go to the hospital because they were worried about the vulnerability, but now they're going to see their physician and the issues have increased. And now it's going to take a bigger intervention and a more costly intervention to be able to address the issue. So people in this moment are feeling that relationship between health and economics in a major way, in a way that the women in my book certainly experience. So number two is we got to think about the economic piece of mental health, not just in terms of affordability, but the ways in which economic vulnerability, whether you're middle class, whether you're working class, whether you're poor, any sense of vulnerability in your current state is going to be a potential trigger around negative health. Around mental health.
And
The
so
third
many people in the middle class are one accident away from.
One accident away. Absolutely. And that's why it's so interesting. So many people, when they first read my book, they said, oh, it's mostly about poor women. But so many of the lessons, basically, these women were the canary in the coal mine, Diego, to be honest with you. They were the canaries in the coal mine that now we're living a lot of what they lived 10 years ago, 20 years ago, 15 years ago. And we're not able to separate the distinction. The third thing that the HIV community does very well is they offer social support. So they understand that it's critical to connect people to other folks you can talk to peers who can offer support, to support groups, to they have case management services within the HIV realm, and that's something in the mental health realm in terms of how do you connect people to providers? Who's that intermediary, right? And who's offering that support as an intermediary until the person gets into the first thing that we talked about, which is dedicated mental health care. So social support is really important to kind of combat that isolation and to get people networked, right, in a community of support. And then the last and final thing that the HIV community has done very, very well is that they have built an infrastructure that gives people an on-ramp to political and civic engagement. So going back to what I had to say about storytelling, they recognize that people have very important stories to tell that then can feed back into the system to help make it better. So they really emphasize for people living with HIV, tell your stories and tell it to your legislator, tell it to your employer if you feel safe, tell it to members of your community, because we want to decrease the stigma. We want to pull HIV out of the shadows. We want to pull the struggles around HIV out of the shadows, because that's how we all get educated. That's how we all improve the services. And that's how we're ultimately going to fight the epidemic. So part of what was so fascinating as we talked to the women in the book was that they were doing public speaking events. They had gone to Washington and talked to their state legislatures about, their federal legislatures about the importance of mental health services, about the importance of the Ryan White Care Act, which finances a lot of services for people living with HIV, around healthcare and the importance of healthcare as a need and a human right. So the HIV community understood that people could be given the megaphone in ways that turned out to be really, really constructive. So what I am hoping to see as we navigate those lessons in COVID is for people to continue to tell their stories, because that's how we're going to figure out what the needs are. That's how we're going to figure out how to make the systems better. That's the armor that we're going to develop to be able to push back and say, no, this is what's needed, because here's what we're hearing from people and their experiences. Here's the data that we're collecting as we kind of bundle a lot of stories together and collect it in scientific ways, which is what I do, but even just hearing one story in a way that influences someone who's powerful to make a particular decision. So that's why I think what you're doing at Modern Health is so important and valuable, because it's an opportunity for employers who, yes, are, faced with many, many constraints. And certainly the economic constraints around COVID have been significant, but to prioritize helping people move from dying from to living with to thriving despite, whatever it is that's on the end of that sentence.
Well, and that's exactly what we're seeing. I speak to HR leaders every day who are like, well, we had 1 or 2 leave of absences, but we had no clue how many people were struggling. And globally, depression is the #1 cause of disability or cited disability in the workforce globally, right? So none of this is new. But what is new is people, as you're saying, starting to talk about it and tell their stories and do something like this in the workplace when they're beginning to struggle with something, but before it's at a clinical level, right? And not just thinking about your mental health when it's drastic or too late. And the current system that we have doesn't actually have resources for you, even if you're willing to talk about it before that point. So I want to, oh, sorry, go ahead.
No, go ahead.
I just want to say, I want to ask you one more question, and then we'll move on to questions from our participants. But you've given us so much context, some amazing information. What's one thing that if everyone just tunes in right now that you want people to learn from your research and how it relates to how they can do maybe just a little bit better today?
Healthcare is transformative. Healthcare is transformative. Safety nets more broadly are transformative. What's in a good safety net? Access to healthcare, economic assistance and support, so that people are able to, yes, enjoy the dignity of work, but also don't necessarily have the level of economic hardships that we're seeing when people are out of work, or when people are working and still finding themselves not able to financially support them, their needs and their families' needs. So thinking about how we're paying people and the kind of how we're thinking about economics, I think is key as another piece of the safety net. So for me, safety nets are key. Within that, healthcare is key. It's key. It's transformative.
Thank you so much, Celeste. Madeline, can you read us some questions for Dr. Watkins-Hayes while we still have her?
Yeah, sounds good. All right. So just first off, we're wondering if you could speak a little bit to one story that strikes you as maybe particularly memorable from your work, and maybe one that perhaps changed the trajectory of your work.
Yeah, so I actually want to tell two stories. So I want to tell one story of a woman named Yvette, who I feature in my book. She's a middle-class woman. She actually works for the government and had been working her way up and doing quite well economically. And she was also a woman living with HIV. The shame that she felt, because it was drastic, she felt as though as a member of her family who was doing very, very well economically, she felt as though coming out about her HIV status would suggest that she was less than what her family had regarded her as. She was also nervous about, will I lose my job and will I lose my health care if my HIV status comes out? And then she was dealing with also just the stigma around things like desirability, and finding a mate. So all of that was weighing on her, and she had not told anybody about her HIV status. Her adult son lived with her. He didn't know. Her friends didn't know. Her family didn't know, all because she was worried about what the effects would be if she came out about her HIV status. But with that intensity of holding it in, she talked about how she then started to grapple with obesity. And she talked about gaining weight as her kind of psychological mechanism, first to not have to deal with the intimacy question, and to kind of make herself, in her own perception, even less desirable. And also because her family might notice the weight gain, but she would talk about that more easily than she would talk about why she was gaining the weight and what was behind that. And then when she finally came out about her HIV status and, owned it and worked, and the way that she did that is through dedicated work with a therapist over several years. She lost the weight. She came out about her HIV status to her family. And the difference, you want to talk about dying from to living with to thriving despite, she was dying of shame. And it was showing up, and what could have potentially killed her was not the HIV status, but the effects of the weight gain that her doctors were talking about, in terms of, we're worried about your high blood pressure. We're worried about hypertension. We're worried about heart disease. We're worried about all of these other things. So it's really, that story, I think, really signals the importance of healthcare and having access to that, and having healthcare that's not just about checking her viral loads and looking at the progression of HIV in her body, but looking at how the shame was manifesting back to the physical in ways that could potentially have implications for her. So that story, I think, is really indicative. And the other one that I'll just tell very briefly is the opening line of my book is a complicated statement. And it's from a woman named Dawn, who says, if it weren't for HIV, I'd probably be dead. And you can imagine, we're talking about an illness that's killed over 32 million people around the world. We're talking about, everything that I just told you, a highly stigmatizing illness. It's decreased in terms of how stigmatized it is these days, and that's wonderful. And now you can take one pill a day and have an undetectable viral load, meaning you can't sexually transmit, or effectively there's no risk. So the science is there in terms of where we've seen HIV. And what she was telling me in the course of her conversation is her connection to the HIV community saved her life. She had been dealing with poverty. She was living on the streets. All kinds of horrible things were happening to her. And it was when she came into community, in the HIV community, ended up getting housing at a place like St. Mary's. They connected her to a doctor. They connected her to a therapist. They helped her get economic assistance. They helped her get her first job. They helped her learn how to speak publicly about her HIV status. What Dawn was really saying is, if it weren't for the HIV safety net, if it weren't for the support that the HIV community provided to me, not just about my HIV status, but the other things that I was dealing with, I would probably be dead. And I went, Jonathan Van Ness, the gentleman, the Queer Eye star, had come out about his HIV status in September of last year. And I wrote a New York Times op-ed about it. And Jonathan invited me on their podcast. And I told that story about Dawn. And Jonathan interrupted me and said, I felt the same way as Dawn. If it weren't for HIV, I'd be dead. And here we're talking about an affluent person. We're talking about a white person. We're talking about a male. We're talking about a person who has a number of different privileges. But Jonathan talked about the fact that he was a survivor of childhood sexual trauma as well. And it had been manifesting in all kinds of ways around drug use, around all kinds of things that he was participating in to self-medicate. And it was the HIV community that taught him, no. How about therapy? How about a support group? How about community? How about come and speak and tell your story? So that suggests to me that what we're seeing is the significance and importance of safety nets that catch people when they're in crisis, and catch people and move them from dying from to living with to thriving despite.
I just want to comment one thing, like that the stigma is something that we fight a lot, right? You can, there's a whole lead a horse to water, you can't make them drink. Employers can offer all the mental health services in the world, but we still have to work with internal cultures to make sure that people feel comfortable accessing that, right? And coaching is one way to do that. Talking about mental health as financial and relationships and diversity and inclusion, and not just something that you do when you're depressed, is a big thing. But part of the reason we've seen our success, and part of the reason I think what we do is so powerful, is giving people the ability to have that vulnerability and say, no, I do want help, or I want to maintain my healthy mental health. And that's why I'm engaging with this, not just struggling with it forever and ever. And my generation's doing a bit of a better job about talking about that. I also know I live in California, where we talk about therapists like we talk about coffee, but we're seeing that movement happen a lot, and it's been very powerful. And hopefully what I hope it'll do is keep people from getting to that clinical state by lowering that shame of having mental health, not just mental health difficulties, but having mental health, period.
Right. Absolutely. And I do think, you're seeing a generational change too. I agree with that, Diego. I think that, in my role as a professor, first at Northwestern and now at the University of Michigan, I am really struck by how many of the students are very open about the fact that they see therapists and see it as part of their wellness routine. And both universities have invested significant resources in boosting student mental health services because they see how critical it is. So one of the things that you and I have talked about is that is a generation that is being cultivated around this is a service that is really important to have, it's critical, and it's not stigmatized. And as they move into the employment realm, they're likely going to have an expectation that they're going to have that level of access to care that they did when they were in college. And you're seeing K through 12 programs. And one of the things that, I just saw a story on, I think on, CBS This Morning or something like that. And then I saw it pop up in my kid's school is something called SEL, social emotional learning. So in terms of education, K through 12, there's a kind of movement afoot to build that into the curriculum and to understand that that kind of conversation is just as important as the reading and math conversation. So what you're seeing is generations being developed around the idea that, yes, we talk about our feelings and emotions. Yes, we grapple with those difficult experiences. Yes, we get help for it when we need it. And there's an expectation that there's an infrastructure, right? Whether it was your school, your college or university, there's an infrastructure for it, that group is then going to go into the labor force. And the question will be, are we then able to appropriately respond and understand that that is part of how we think about supporting people in the workforce?
We're already seeing that. We ran a state of the industry report that was published in March, which I really recommend everyone take a look at. And 67% of employees now believe that it's their employer's responsibility to offer a mental health resource in the same way that they offer health, vision, and dental. It's become the fourth pillar of healthcare. So we're already seeing that, and it's only going to become more of an expectation.
Excellent.
So,
and I see we have a couple more things in the chat that I want to make sure we get to. Do you want me to?
One more, and it seems like there's one question from Demetra. Can you speak a bit to the difference between rebuilding a life and
remaking a life? I sure can. That is a great question. And then I'm going to tie it into Karen's question too about what her mother taught her. So rebuilding a life is a return to the prior state. Remaking a life is creating a new state of being. So for many of the women that I talked to who had such a kind of ongoing state of crisis, going back to where they were was not going to suffice, right? They were going to have to completely rebuilding is about designing completely new tools for physical, psychological, economic, and social survival, right? So it's fundamentally changing one's coping strategies and creating a different way of operating in the world that is very different from where one ever was. So that is how I make the distinction. And I just talk about that in my book. So Dimitri, I wonder if you read part of my book. Thank you if you did. To Karen's point, my mom taught me how to survive. I am now learning how to live. This is so interesting in the context of joy. And you probably might have noticed that joy is now part of the kind of national conversation. And specifically, I'll use the term Black joy when we think about what I see a lot in terms of African Americans, Black people talking about Black joy. When a group or an individual has been under a severe level of oppression, stress, trauma, etc., joy is an act of resistance. Right. So the notion of what Karen's mom is talking about is in this moment, my job is to teach you how to survive the oppression, how to survive the racism, the sexism, perhaps the classism that you may experience in the world. My job is to help you navigate those very, very turbulent waters. And perhaps you're navigating it from loving my child, but I only have a rowboat to offer her, right? I don't have a yacht to offer her. So I've got to make sure that she knows how to row and row well in order to survive. So what Karen is gesturing to is that work, though, is exhausting. And that's not the only part of life, right? There should be joy. There should be happiness. There should be love. There should be peace. There should be excitement, right? And that is an act of resistance because that's been denied to so many people for so long. Or it's been something that's been vulnerable because you never know when the other shoe is going to drop. So I so appreciate your point, Karen, because what you're saying is you are being agentic and powerful in, yes, mama gave me the rowboat and all the tools that she could, but I also recognize that I want to row towards the rainbow, right? That I want to enjoy the beauty of that. That I want to row to peaceful waters and enjoy that. That maybe I want to row to a yacht. Maybe, and it's my right to be able to experience that part of life. And the final thing I'll say about the analogy between the yacht and the rowboat, there's nothing wrong with having a yacht. But what I would ask is for us to be thoughtful and mindful about the disparity between what it means to have the yacht and what it means to have the rowboat, and ask us to think about how can we begin to equalize things in a way that gives more people the opportunity, and maybe perhaps gives up some of the privilege that we enjoy in our in our yachts.
Thank you so much, Celeste.
Mm-hmm.
Thank you, everybody, for joining us. We are running out of time. We are going to send a recording of this, so feel free to share it with your friends, family, employers, or employees. And once again, thank you, Dr. Watkins-Hayes, for your time. I really recommend that everyone check out her book on Amazon. We'll be sending out that link as well. And any last words, Dr. Watkins-Hayes?
Thank you so much. Yes, the book is available as an audiobook, Kindle, paperback, wherever books are sold, Amazon, etc. If you go to my website, celestewatkinshayes.com, all one word without the hyphen, please, be in touch with me. I'm happy to make arrangements to sign your copy of the book. And I encourage you, however you consume books, the audiobook is really great. We just got it done. And the narration is by an actor named Charisse Booth, who just brings the book to another level of life. So I definitely encourage you to check that out. Thank you so much, Diego. I am so proud of you.
Thank you.
And I'm so happy that you're doing this work. It's important work. It is life-saving work. And it is hopefully going to create a revolution in our world around mental health and wellness.
We hope so too. Thank you so much, Celeste. And thank you for everybody for joining. We'll follow up soon. Bye, everybody.
Bye-bye.